Welcome to this comprehensive lecture on reactive airway disease in children, presented by Pediatric Case Review. Today, we will explore the clinical presentation, pathophysiology, diagnostic approach, and treatment strategies for this common pediatric respiratory condition. This lecture uses case-based multiple-choice questions to enhance your understanding. We will cover 12 clinical cases that address key aspects of reactive airway disease management. Let us begin our educational journey. Here is our first case. A 3-year-old boy presents to the emergency department with difficulty breathing. His mother reports he has been coughing for 2 days, and tonight she noticed a whistling sound when he breathes out. He had a cold last week. What is the most characteristic finding in reactive airway disease? Option 1, inspiratory stridor. Option 2, expiratory wheezing. Option 3, barking cough. Option 4, grunting respirations. The correct answer is number 2, expiratory wheezing. This is the hallmark clinical finding in reactive airway disease. Wheezing occurs during expiration when narrowed airways create turbulent airflow. The whistling sound results from air being forced through constricted bronchial tubes. This differs from inspiratory stridor, which suggests upper airway obstruction. Barking cough indicates croup, while grunting respirations suggest parenchymal lung disease. Expiratory wheezing remains the key diagnostic feature. Here is case 2 regarding triggering factors. A 4-year-old girl has recurrent episodes of coughing and wheezing. Her symptoms worsened during spring and after playing with her pet cat. Which factor is most commonly associated with triggering reactive airway episodes? Option 1, bacterial infections only. Option 2, allergens and respiratory viruses. Option 3, food allergies exclusively. Option 4, weather changes only. The correct answer is 2, allergens and respiratory viruses. These are the most frequent triggers for reactive airway disease in children. Common respiratory viruses include respiratory syncytial virus and rhinovirus. Environmental allergens such as pollen, pet dander, and dust mites also provoke symptoms. Cold air and exercise can trigger episodes as well. Understanding these triggers helps families implement avoidance strategies and recognize early warning signs of exacerbations. Case 3 focuses on physical examination. A 2-year-old with known reactive airway disease presents with acute symptoms. On examination, you observe his breathing pattern carefully. Which physical examination finding indicates increased work of breathing? Option 1, regular respiratory rate. Option 2, subcostal and intercostal retractions. Option 3, pink mucous membranes. Option 4, normal oxygen saturation. The correct answer is number 2, subcostal and intercostal retractions. Retractions indicate significant respiratory distress and increased work of breathing. When children struggle to breathe, the spaces between ribs and below the rib cage pull inward. Other signs include suprasternal retractions, nasal flaring, and use of accessory muscles. Tachypnea often accompanies these findings. Recognizing these clinical signs helps determine severity and guide treatment decisions in the emergency department. Here is case 4 regarding auscultation findings. During examination of a 5-year-old with reactive airway disease exacerbation, you auscultate the chest. What would you most likely hear on auscultation? Option 1, bronchial breath sounds. Option 2, diffuse expiratory wheezes. Option 3, pleural friction rub. Option 4, absent breath sounds bilaterally. The correct answer is 2, diffuse expiratory wheezes. Wheezing occurs when air is forced through narrowed airways, creating high-pitched musical sounds. The expiratory phase is typically prolonged during reactive airway episodes. Wheezes are usually bilateral and diffuse. In severe cases, you may hear decreased air entry due to significant airway obstruction. Silent chest with absent breath sounds represents a medical emergency requiring immediate intervention. Normal bronchial sounds and friction rubs are not typical findings. We will now move to case 5, which focuses on understanding the underlying mechanism of this condition. What is the primary pathophysiological mechanism in reactive airway disease? Option 1, vocal cord dysfunction. Option 2, bronchial smooth muscle constriction and inflammation. Option 3, alveolar collapse. Option 4, pulmonary edema. The correct answer is 2, bronchial smooth muscle constriction and inflammation. In reactive airway disease, exposure to triggers causes airway inflammation and edema. Bronchial smooth muscle contracts, narrowing the airway lumen. Mucus production increases, further obstructing airflow. This combination results in the characteristic wheezing and respiratory symptoms. Understanding this pathophysiology guides treatment decisions. Bronchodilators relax smooth muscle, while anti-inflammatory medications reduce airway edema and prevent exacerbations. Case 6 focuses on diagnosis. A 3-year-old has had 3 episodes of wheezing over the past 6 months, all triggered by viral infections. How is reactive airway disease typically diagnosed in children under 5 years old? Option 1, spirometry testing. Option 2, clinical history and physical examination. Option 3, chest CT scan. Option 4, allergy skin testing. The correct answer is number 2. For children under 5 years of age, diagnosis relies primarily on clinical history and physical examination. Young children cannot reliably perform spirometry testing. Physicians assess recurrent wheezing episodes, triggering factors, in response to bronchodilator therapy. Family history of asthma or atopy supports the diagnosis. Formal asthma diagnosis typically occurs after age 5, when pulmonary function testing becomes feasible. Clinical assessment remains the cornerstone of diagnosis in preschool children. Let us look at case number 7 regarding pulmonary function testing. A 7-year-old child with suspected reactive airway disease undergoes spirometry. Results show FEV1 at 70% predicted. What finding on spirometry would confirm reversible airway obstruction? Option 1, no change after bronchodilator. Option 2, FEV1 improvement of 12% or more after bronchodilator. Option 3, decreased vital capacity. Option 4, normal FEV1 to FVC ratio. The correct answer is number 2. Reversibility is a key diagnostic feature. Significant reversibility is defined as 12% or greater improvement in FEV1 after bronchodilator administration. This confirms that airway obstruction is reversible rather than fixed. The FEV1 to FVC ratio is typically reduced in obstructive lung disease. Bronchodilator reversibility testing distinguishes reactive airway disease from other respiratory conditions. This objective measure helps guide diagnosis and treatment planning. Here is case number 8 regarding imaging indications. We have a 4-year-old presenting with wheezing. You consider ordering a chest X-ray. Which scenario most strongly indicates the need for a chest X-ray? Option 1, typical wheezing responsive to treatment. Option 2, unilateral wheezing with fever and asymmetric examination. Option 3, mild intermittent symptoms. Option 4, known history of reactive airway disease. The correct answer is option 2, unilateral wheezing with fever and asymmetric examination. In most cases of typical reactive airway disease, chest X-rays are not routinely necessary. However, asymmetric findings raise concern for foreign body aspiration or focal pneumonia. Other indications include lack of response to standard treatment, unexplained fever, or severe respiratory distress. Chest imaging helps exclude complications and alternative diagnoses when clinical presentation is atypical. Here is case 9 regarding emergency management. A 3-year-old child arrives with acute wheezing, retractions, and oxygen saturation of 90% on room air. What is the first-line treatment for acute reactive airway disease exacerbation? Option 1, oral corticosteroids only. Option 2, short-acting beta-2 agonist, specifically albuterol. Option 3, antibiotics. Option 4, chest physiotherapy. The correct answer is 2, short-acting beta-2 agonist, specifically albuterol. This medication rapidly relaxes bronchial smooth muscle, providing immediate relief. Administration can be repeated every 10 to 15 minutes as needed. Oxygen supplementation is indicated if saturations fall below 90%. Systemic corticosteroids are added for moderate to severe exacerbations. Frequent reassessment guides ongoing management. Antibiotics are not indicated unless bacterial infection is suspected. Bronchodilators remain the cornerstone of acute treatment. In this case, we have a 6-year-old with symptoms occurring 3 times per week and nighttime awakenings twice a month. The question is, which medication class is the preferred controller therapy for these persistent symptoms? Option 1, short-acting beta agonists. Option 2, inhaled corticosteroids. Option 3, oral antihistamines. Option 4, antibiotics. The correct answer is option 2, inhaled corticosteroids. These are the preferred first-line controller medications for persistent reactive airway symptoms. Inhaled corticosteroids reduce airway inflammation, prevent exacerbations, and improve overall symptom control. They should be used daily, even when symptoms are absent. Short-acting beta agonists serve as rescue medications for acute symptoms. Establishing controller therapy early prevents disease progression and reduces emergency visits. Daily compliance is essential for optimal outcomes. This is case number 11 regarding treatment escalation. The scenario involves a 5-year-old on low-dose inhaled corticosteroid who continues to have symptoms more than 2 days per week despite good compliance. What is the next appropriate step in management? Option 1, stop all medications. Option 2, add long-acting beta agonist or increase steroid dose. Option 3, switch to antihistamines. Option 4, start antibiotics. The correct answer is number 2, add long-acting beta agonist or increase steroid dose. When symptoms persist despite low-dose inhaled corticosteroids, therapy must be stepped up. Options include increasing the corticosteroid dose or adding a long-acting beta agonist. Leukotriene modifiers represent another alternative. Before escalating therapy, reassess medication technique, compliance, and environmental triggers. Regular follow-up ensures treatment adjustments achieve optimal control. The stepwise approach to management tailors therapy to individual patient needs. Here is our final case regarding the long-term outlook. The question asks, what is the typical long-term prognosis for children with reactive airway disease? Option 1, all children develop chronic lung disease. Option 2, many children improve with age, though some continue into adulthood. Option 3, symptoms always worsen over time. Option 4, complete resolution occurs in all cases by age 5. The correct answer is number 2. Ideally, many children with reactive airway disease will see their symptoms improve or resolve as they grow older. However, some children develop persistent asthma continuing into adulthood. Early intervention and proper symptom control help prevent complications. Regular follow-up allows for treatment adjustments. Factors affecting prognosis include severity, trigger avoidance, and treatment compliance. The overall outlook remains favorable for most children with appropriate management and monitoring. I would like to invite you to join our Patreon community, named Pediatric Case Review. This community offers all videos organized by system, making it easy to access our complete video library. All presentation slides are available as downloadable images, perfect for study and review. You will also find practice questions and study materials to enhance your learning. For details and subscription information, please comment below in this post, and we will message you with complete information. Thank you for watching this presentation on reactive airway disease in children. We hope this review has enhanced your understanding of this important pediatric condition. Please subscribe to Pediatric Case Review for more educational content covering various pediatric topics. If you have any questions, drop them in the comments below. We encourage discussion and learning. Stay tuned for our next lecture. Thank you again for your time and dedication to pediatric education.